Welcome to the Sustainable Clinical Medicine Podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hello, everybody, and welcome back. Today we have with us Dr. Susan Wilson, who is going to introduce herself in a moment. Susan works in the coaching space, but has left medicine, but she'll tell us that story. So I'm going to let you introduce yourself to us. Welcome.
Well, it's great to be here, Sarah. Thank you so much for having me on the podcast. So yes, I am actually an emergency medicine physician. I practiced in Milwaukee, Wisconsin, so in the Midwest. And I started my practice in 1993. I finished residency in 93 and actually practiced until 2017. I actually had to retire from clinical medicine because I have a retinopathy, which caused a progressive distress with my vision and to the point where I really couldn't work anymore. And so at that point, I was trying to think about, well, how can I still be involved in medicine? Because I just really love working with people and I just love the healthcare space. So that's when I came to the world of coaching. And so I have subsequently been focused on trying to support people in healthcare, around issues of burnout, job satisfaction, work-life balance, those sorts of things.
Love it. Okay. Let's walk you back to kind of that 1993 or maybe even earlier. How was medicine for you? What was your journey like through training and into your early career? How were things for you?
You know what? Honestly, I have to say I feel very blessed. I was very lucky because I feel like I did have a good experience. I mean, as good as an experience can be when you're a medical student and a resident, right? I mean, we all know that there's definitely some real challenges there in terms of, just the time commitment and the things that you have to really just give up for your career. But I did have a great group of friends and actually met my husband in medical school. Actually, he's also an emergency medicine physician. So, we kind of traversed the journey together. I will say that, yes, definitely starting out, definitely a challenge in terms of thinking about how can I practice medicine, but still have a life, right? Still do things outside of medicine. And interestingly, I actually started out in general surgery. I really wanted to be a vascular surgeon. That was my dream. I loved vascular surgery. And I very quickly realized after the first year and a half of my residency that, this is not sustainable for me personally. I recognize that, I want to be married. I want to have children. I just recognized there were other things that I wanted to do with my life. And so that really gave me pause to kind of take a step back and think about, okay, what can I do in medicine that can still help me to also be able to do the other things that I'm so passionate about. So that's actually how I came to kind of decide on emergency medicine. I think for me, I really like the fast pace. I mean, I think, the surgical world is the same way. It's like fast paced. It's like you're doing things, but I liked the control of my schedule in terms of shift work. And of course, that's not without, some caveats because of course it's 24/7. So the shifts do include night shifts. They include weekends, holidays, right? But I felt that at least gave me a little bit more control in terms of, when am I going to be working and when am I going to be, off and available for my family. So that was one thing I think that really helped me was just kind of recognizing, what specialty, what area I could be in that would still allow me to do other things. And then I think the other thing for me, I was very fortunate that I was able to practice part-time. I don't think I ever was really working full-time. I think the most I worked was probably 75 or 80% of an FTE. So that also and our eldest child was born in 1993, and then we had another child in 96. And so having two very young children early on, in our careers, it was nice for me to be able to work part-time. So that also really helped a lot.
Got it. Yeah. Tell us about the emergency department and the shift management of the things other than you got your patient management and then there's the
Mhm.
documentation and the follow-up of results. How did that all kind of meld together for you?
Well, it's interesting. One thing that I think really helped a lot, and this wasn't something that we had initially, but in the last probably 10, 12 years of my career, we started having scribes working side by
Mhm.
side with us. And so the thing that was so nice about that is that really allowed us as the clinicians to spend more time with the patients, talking to them, really having as much time as possible with them, taking history and all that sort of thing. And then having a scribe next to us that's actually doing all the documentation. And then similarly, when you're coming out of the room and sitting down at the computer and having to find the labs and stuff, I mean, good scribes would really help you. They would help to pull together the data that you had to look at. And so I think that really did help a lot in terms of being able to maximize, the amount of time that we spend doing things. I mean,
What was it
certainly,
like?
I was going to say, certainly at the end of the day, we're
Yeah.
the final say. So we have to review the chart that the scribe has put together, and we have to review everything. But I definitely think that having an extender like that definitely helped.
Yeah. What was it like before the scribes came in? Like, why did the department look for scribes?
Oh, well, I think we recognize that, it definitely was taking away from the patient care,
Mhm.
having to spend so much time charting and worrying about, the specific phrases that we had to include in charts to, for any given chief complaint, et cetera, et cetera. So I think everyone recognized that we could maximize our face-to-face time with patients if we had somebody else assisting us.
Okay. And then at the end of the shift, because emergency departments, we all get into a rut of how we work. Like, what was your rut before the scribes came along? How would you do your work? What was the workflow for you within a shift?
Well, it's really interesting. I remember very, very clearly as a resident, we would work 12-hour shifts. And so, literally, at the end of that 12-hour shift, they were 7 to 7 shifts. The new resident would come on and we would literally, quote unquote, run the board, right? So, we would turn over stuff immediately. And when I finished residency and was out in private practice, that culture didn't really carry forward. And so there were many times when, you'd maybe be halfway through a workup of a patient,
Mhm.
or maybe, that you're just waiting for one thing to come back to make a final disposition. And instead of signing that out to the guy that was coming on for you, you'd kind of sort of feel obligated, like, oh, I'm just going to take care of this.
Mhm.
And so that did, definitely, I mean, if I'm, for example, was scheduled to work 7 to 3, I
Mhm.
would not assume I'm going to walk out at 3 p.m. I would think, oh, maybe 4 o'clock. That will be good. So,
Right. Okay. Yeah.
and I think also in emergency medicine definitely had the same challenges that people, in primary care, people that are in an office-based practice have in terms of charting.
Mhm.
So, certainly before the scribes, had a lot of charts that still had to be finished. And if you were really just wanting to get out of the department, of course, like everybody would do, right? Sign on from home, from the computer at home to finish charting, that sort of thing.
It's so interesting that one that you had the ability to do that from the emergency department because I know that as I was coming through emergency in my early career, it was a really good fit for me with the second baby that came along. I would do the 3 to 11 shift because it
Mhm.
just worked. I could be there in the morning, head off to work and be home kind of for the nighttime feed. Um, that watching your colleagues do this and and we didn't have access from home for the emergency department or for the hospital,
Mm,
as within that time, that same kind of time frame.
hmm.
And so we would have to finish everything before we went home. And watching some of your superiors, supervisors, preceptors who were doing their notes as they went, and others who had this big pile just kind of
Right.
continuing to collect through the shift,
Hmm.
and watching the two different styles. I didn't even have the perspective of what I wanted. I was just kind of the noticing of how people would do things differently within the day.
Hmm.
And that's why I like to kind of get in and say, how are you doing it? What did it
Right,
look like
right.
for you? How long did it take you at the end? Because it's so fascinating to us if we start to be curious about our workflows. We do things the way we do things because we do things the way we do things.
Right. Well, and I think the other thing you're getting to is, people's different practice styles and it's
Mm,
different practice styles in terms of their interaction with their patients and with their charting and what they order and all that. And so, yeah, definitely. I mean, there were, and I will say that when I first started working and actually as a resident, I mean, we hand wrote charts. We did not
mm,
have the electronic medical record. We had handwritten charts, and literally the attending, when I was a resident, would scribble a little, agree with above or whatever. They would add a note. And yeah, you'd think about how inefficient that really was. But I do think it's interesting when you observe, your colleagues. Some people are such perfectionists and would spend so much time. And I think finding that sweet spot, right? Finding the spot where, okay, I'm documenting what I need to document. The information that I need to convey is in there, but maybe it's not said as eloquently as possible, and being okay with that. I think
mhm.
that's the big challenge, I think, for a lot of people. And I think even still now with the EMR and knowing you don't have to go back 5 times and make sure you have the exact specific word that you want to use for a term or a phrase.
Yeah. What happened with the workflow with regards to the scribes were doing the charts, but you still have to review what was written and sign
Mhm.
off on it. When did that happen for you within the shift?
Oh, within the shift. You know what? I honestly, I would try to keep up, even if I only
Mhm.
did one or two charts. Maybe if I had a little bit of a lull, maybe there was 5 or 10 minutes between seeing a patient and seeing the next patient or waiting for some labs or whatever. I would try even to do one or two charts, that kind of review. And some of them, admittedly, were very simple, straightforward things. I mean, if somebody came in, like with an ankle sprain or some very minor complaint that you knew that there wasn't really much to say about the history and there wasn't a whole lot in the exam, that those were easy to finish up. The ones that, certainly would take more time are, of course, those medically complicated patients or people that ended up having a lot of procedures done and those sorts of things. And I guess I would have to say that those tended to be the ones that, yeah, I probably at the end of my shift, then when I
Mhm.
felt like I had a little bit more time to just zero in on that, is when I would do those.
Got it. Yeah. How long do you think it took you to change up the way you did things so that your scribe could understand what you'd done for the exam? Because that's not, because normally, you're doing your exam and then you get to write it down after. But if you got a
Mhm,
scribe there, they got to either watch what
mhm.
you're doing or you got to say it out loud.
Right. Well, that's actually, it's interesting. That's kind of what we learned to do is
Mhm.
as we were, and I sort of remember even in the early on working with the scribe, getting used to that, saying to the patient, okay, just so you know, I'm going to be talking out loud and this person here that's documenting everything that I'm going to say out loud what I'm hearing, what I'm seeing, what I'm doing.
Mhm.
And so yes, I mean, definitely you're right. You would literally say the things out loud. Especially, you think about the heart and lung exam, you'd say, their lungs are clear, their heart is normal, there's no murmur, blah, blah, blah. So definitely I think saying it out loud in real time really made a big difference.
Mm, yeah, interesting. Then, so you've got two little people and you're working in Emerge, you're working semi-part-time, you've got a husband who's also working Emerge. How are things going through that those, what, 20 years, pretty much more
Yes,
than.
pretty much. Yeah, yeah. You know what? It went pretty well. I think my husband and I kind of decided, I mean, that our children were going to be our number one priority.
Mhm.
And so as a result of that, we literally were tag teaming with each other. We wanted, we wanted to minimize the amount of time that they had somebody else taking care of them. And I mean, certainly there were times when we had to have
Mhm.
babysitter or, a nanny, somebody that would be there for a few hours if there was an overlap with the two of us. But yeah, so for example, maybe my husband would um, work a night shift and I was working a day shift. And so he would literally come home at night and I would leave probably before he got home and I would work all day. And while he's sleeping, we'd had somebody there that was taking care of the kids.
Mhm.
But yeah, those were definitely, I think, challenges is finding what's the right balance. And certainly as they got older and then they were involved in activities, that's a whole nother challenge because then you're trying to balance not only working, but then also being present for anything that the kids are doing. And
Mhm.
so, yeah, so I do feel like in the end, I'm really glad that we were able to, again, the idea of the shift work and not working 100% of an FTE helped to give us a little bit more flexibility.
Yeah. Did you have to manage any of your like in baskets for things that might have taken a few days to come back after patients were seen? Is that something that was part of your personal requirements, or it was handled by the department?
Yeah, we were very lucky because we did certainly, we would send cultures in the emergency
Mhm.
department. I mean, you think about
Mm.
somebody getting blood cultures or like a swab, like if you did a rapid strep, but then you got a throat culture, right? So there's all
Mhm.
these a swab of a wound. And so when all of those results would come back, we were very lucky because we did have mid-level providers in our departments. So whether, nurse practitioner or physician assistant, and they would actually handle all of those types of things, culture results. And then if there was something, somebody needed a switch of an antibiotic, let's say maybe a
Mhm.
urine culture was, they were resistant to what they were put on, then our mid-level providers would actually handle that. They would call the patients and do that. Now, any x-ray discrepancies that came in after the fact, for example, maybe an x-ray was read at night,
Mhm.
and then in the light of day, somebody sees something else. And so those were actually handled by the physicians because
Mhm.
those were, I mean, especially some of those things, like if a CT scan was initially, let's say, read as negative and you're looking for an appendicitis,
Mhm.
and then the radiologist calls and says, well, actually, this
Mhm.
looks a little suspicious. If the patient hadn't been admitted and then for sure the physician was taking care of those kind of calls.
So the physician on call or the physician who
The,
ordered
the,
it?
the physician in the emergency room at the
Yeah.
time.
Okay.
Yeah,
Okay. So it was not your personal in basket to handle when you weren't on shift.
correct.
It was being looked after, but it's also then part of today if you're on call.
Right, right, right. So for
Hmm.
example, if my partner was working during the night, the 11 to 7 shift, and he ordered a CT scan, let's say, to rule
Hmm.
out appendicitis, and it was read during the night as negative, and the patient seemed fine, and they discharged them. If I come in at, 7 a.m. and then at 7:30, the radiologist during the day has, overread the CT and says, hey, this looks suspicious, that then came to me and I pulled the chart up and reviewed it and then called the
Hmm.
patient. So yeah, that's
Yeah.
how that worked.
Okay. So that's adding another layer to your day though. Like
It
it's
is for
another
sure,
responsibility of sorts with regards to the how the day's going to go. I
for
know
sure.
that for sure I don't know whether it's the volume or complexity or the bed blocks of getting people upstairs. The emergency department, wasn't it lovely when we could kind of hand over the patients in an empty waiting room? But
Yes.
it's
I
just not a
think those,
thing.
I was going to say, I think those days are over.
Yeah, I think those days are
Yes.
over. It
Hmm.
it's that even the pause between patients, you can say, some shifts just there, you're just running from the second you walk in the door.
Hmm. Hmm.
It can feel so overwhelming and as if there's no control or it just overwhelming for the
Hmm.
physicians and the staff working. what sort of things did you find that that overwhelm and the busyness sometimes just the demand, and did you have any strategies or resourcing around that within your spaces?
Well, so really interesting. Yes, definitely had periods of time when I felt a lot of overwhelm. And I do feel that as I got older in my career, I felt like um, my ability to, bounce back from some of these stressful situations became less and less. And so
Mm,
I felt like it was more and more anxiety provoking. And then, as I said, I had to retire in 2019 because of my vision. And so I, kind of shifted gears and, kind of reinvented myself as a coach. And part of that reimagination was learning this whole concept of mental fitness.
mm,
And I did that for myself personally. But then as I learned the concepts and the techniques of becoming mentally fit, I really could see how this would really help people in terms of the stress and anxiety and the feeling of overwhelm in any aspect of medicine. And so that really moving forward has been what I've really tried, to emphasize with clients in terms of learning how to become mentally fit so that yes, you can minimize the overwhelm and or learn how to deal with it.
yeah. Can you walk us through what it was like to experience a health condition that impacted your ability to continue working?
Yeah, well, it's been so many years that I feel like I've kind of come full circle. So I first started having issues with my vision back in, oh my gosh, like 2015.
Hmm.
And it just kind of gradually got worse and worse. I subsequently had surgery on both eyes to try to, minimize the damage to both retinas and kind of stabilized one eye. One eye is kind of progressively worsening. And so basically what that has caused is just distortion of my vision. I mean, I can still see, but everything, a straight line is squiggly. It's really
Mm,
difficult to read anything. So when that started happening to me, I mean, here I am, I'm in my early 50s and, I'm just thinking, oh my gosh, what is happening? I'm too young to have something like this happening to me, So
yeah.
I honestly really feel like I did go through all of those Kubler-Ross stages. I was initially in denial, then I was
Yeah.
angry, and
Yeah.
then I was, very, very depressed about the whole thing. And ultimately got to the point of acceptance. And that's, where I've landed. And I kind of feel like, you know what, this is my new normal.
Hmm.
And instead of focusing on all the stuff now that I really can't do or I can't do
Hmm.
very well, I'm really kind of choosing just to think about, oh, well, yeah, I can still play golf. I just have to patch one eye. Or, um, I can still drive when I know exactly where I'm going. And I'm very conservative about where I'm going to drive and when I'm going to
Hmm.
drive. And, so I think and that then that gets into this whole concept of post-traumatic growth and recognizing that, what, from these bad situations like this, that, you can actually grow and you actually can find some new opportunities. I never would have gone into the world of coaching had it not been for my vision issue. So,
Yeah.
trying to just continue to move forward and just recognize this is just yet another chapter in my life.
Was there anyone, or did you have a friend group or something that knew what was happening early on when you were kind of in that there's something happening to me kind of moment?
Mhm.
Um, Tell us about that. What helped you?
Well, I will say definitely my husband. And uh, kind of as a side note, a little tangential to our discussion, is I'm very interested in this whole concept of peer support for
Mm,
people that have had, really traumatic things happen at work and having support. And so I feel like I was very lucky because I had a built-in peer support. My husband, is my husband, also a physician. and so could really understand. My mother actually also was a physician, and so at the time when I'm going through all of this, she was also able to support. So, I think just having people to be able to, um, kind of confide in and talk about, how difficult it was, made it easier. And interestingly, along the way, I would meet people even at work that I would tell them about my vision struggle, and they'd be like, "Oh, well, I've had an issue with, with my retina as well, and I've had a detached retina, or I've had this or that." And so yeah, I think just by reaching out and by connecting with other people, really helped me a lot.
Yeah. Did you use a coach, or did coaching how did you come to the coaching thing? Like, I'm curious where it arrived.
You know what? That's a great question because I've actually thought about that. When I think back, to 2019, and I think
Hmm.
about how did I ever get this idea?
Yeah.
Because I had not personally up until that time really, I mean, I certainly had not used a coach myself. But I think I just really started brainstorming, and maybe even I maybe did a Google search on maybe alternative careers in medicine
Hmm.
or something.
Hmm.
And so yeah, so at some point, yes, I became very aware of this whole concept of physician coaching. Oh, and and I think the other thing too that maybe also kind of sparked this interest in actually coaching is right before I retired, I heard a lecture about second victim syndrome, which I
Hmm.
had never heard that term before. Never. I mean,
Hmm.
and once I heard this lecture and I started thinking about the implications of that, I thought, you know what, I've been living this. My entire
Hmm.
career has been moments of second victim syndrome.
Yeah.
And knowing that peer support was really, really is the way to help people, kind of navigate through those situations made me think, I really want to help people get through this because I have been through those situations time and time again. And so I think that also really kind of spurred me on and kind of led me to the idea of coaching.
Hmm. All right, there you go. And so,
Yeah.
so you transition out of emergency medicine. You kind of gave us a glimmer that that was not easy or fun.
Right.
And then you heard about this thing, second victim syndrome, and you'd already indicated that seeing some of those hard things in emerge is hard. It doesn't get easier with time. In
Hmm.
fact, you felt like it was getting harder and
Hmm.
harder to do those heavy pieces that we see in emerge.
Hmm.
And then you hear the second victim syndrome, you're looking for a new career. And that's bravery right there to say, I'm going to go reinvent myself and figure it out. That's pretty cool.
Well, thank you. Well, you know what? It's kind of out of necessity. I mean, I felt like, I still wanted to find something that would
Mm,
intellectually challenge me.
yeah.
And so I thought, you know what, this is such a great thing because there is so much to learn about. And, that's the one thing I think that's the beauty of coaching are there so many resources out there that coaches learn about that then they
Mhm.
can subsequently share with their clients. And so, and for me personally, I got a lot of benefit just for myself in terms of those resources. And then learning those and then being able to pass those along to other people that were struggling was just, it just felt like that seemed like the right thing to do.
Yeah, love it. What sort of things did you do within the new you, the new coaching version of you? What took your interest? Who do you help?
Well, so primarily physicians, but as I said, I've also worked with mid-level providers, nurses, but mainly physicians. And I've I've had several physicians that I've worked with specifically around, they will have a specific acute adverse event that happens to them. They're part of, they are experiencing a second victim syndrome situation. And so those people, I really do love helping them through that. And as I said, this idea of becoming mentally fit
Mm.
and helping people to learn, what does that mean? What does
Mm.
that look like? How do, what are the techniques? How do I do that? That's been very gratifying.
Yeah.
And so specifically, the idea is, we have all of these thought patterns, negative or positive, we have all these thoughts going on in our brain. And the idea is, we have these saboteurs, if you will, that generate these negative emotions that we have. And then on the flip side, we have, for lack of a better word, our sage or our best self,
Mm.
which is where we derive, the positive emotions that we feel. And so the idea is that if you are mentally fit, you recognize when you are being sabotaged, when you're having thoughts or you're having situations or emotions coming up that are making you feel something negative, whether it's anger, frustration, or fear, recognizing that that's happening, and then actually using some mindfulness techniques to kind of short circuit that and kind of consciously, or commanding yourself to shift away from that and getting back in touch with your best self. And our best self has all of these inherent powers, and kind of learning how to then connect with our inherent powers that we have, like being curious or empathizing with someone or being able to innovate and brainstorm about a situation. And so shifting away from the negative towards the positive, and over time, doing that over and over, you're really strengthening your pathway of your sage or your best self, and you're weakening those saboteur thoughts. And so
Yeah.
that's the whole idea of the fitness part of it.
Got it. Okay. So it's not that, because I know that as physicians we can deny our emotional state for so long.
Mm-hmm,
Like you just
mm-hmm,
put
mm-hmm,
it aside.
mm-hmm,
Doesn't matter that you'd rather be teared up and
mm-hmm.
really mad or sad about what you just saw in that first
Right.
room. You kind
Mm-hmm,
of bury that to go into the second room. So
mm-hmm,
this is different from that. You're not saying that you can't be frustrated.
mm-hmm,
You're saying that when you notice frustration, it can sometimes just be trying to sabotage you. It's just
mm-hmm,
there on
mm-hmm.
repeat, creating this constantness of emotion. And you still have the ability to find something less hurtful towards you.
Right, right. Yeah, I think the important thing and I've said this to a lot of my clients, the important thing about this idea of mental fitness is that we're not talking about suddenly being toxically positive. It's
Mm.
not like, oh, everything is fine and
Yeah.
no, nothing bothers me. That's not what it is. It's basically that knowing that, yes, I am still going to have situations, thoughts, come up that are going to make me feel a negative emotion. And when that happens, learning how to help myself shift away from that. And, like another concept with that is, recognizing a negative emotion, recognizing it, and just letting it go. Like recognize, labeling it, I'm feeling really angry right now. Okay. Okay. It's gone. And that's another strategy that people oftentimes use. But I do like one analogy with this mental fitness work is this idea of the hand on the hot stove.
Mhm.
And so, for example, let's say we're at work and something happens that makes us really frustrated. I mean, maybe it's like opening um, a note in the portal, like there's maybe a patient communication that's really frustrating, or maybe seeing a patient that, just always makes you a little agitated, whatever it is, recognizing that that's happening and that's a negative thing. So, if you put your hand on a hot stove and that's hot and it's going to burn you, if you recognize that immediately and you pull your hand off, you've really minimized any injury. But if
Mm.
you put your hand on that hot stove and you just ignore it, it's like, this negativity, but you're ignoring it, you're not doing anything about it. Over time, you have a serious burn, right? Because you've left your hand on that hot stove. So that's one analogy of thinking about, these negative emotions as being sort of a warning that, hey, something's not quite right here.
Yeah.
And I want to shift away from that. These things are going to continue to happen, but learning how to react to them and to shift away from them is the key.
Got it. Okay. Yeah. So we have situations come up. Um, we get an emotional reaction and then giving us some control, some ways that we can, ideas we can start to be curious about that might not keep us constantly in that state of frustrated, overwhelmed,
Mm-hmm, mm-hmm.
irritable,
Right,
dread.
right.
Yeah, because I think that sometimes it's hard to even conceptualize there's a choice when you're dreading work every day and when
Mm-hmm,
you're
mm-hmm,
feeling exhausted and when you're feeling like you can't do this anymore and patients and you got this story about the patients, the workplace, the system, the healthcare
mm.
system,
Right,
the pay
right,
you're
right.
getting, like you have
Mhm.
this opinion. It's a constant reel in your head and it
Mm-hmm.
can feel very confronting to know, hey, you still have choice. You still
Right.
can create something that feels more relieving than what you're
Mm-hmm.
experiencing.
Right. Well, and I think also one thing, again, this kind of makes me think about is being able to take a step back and really ask yourself, what about this career? What about my career in medicine, drew me here in the first place? What brings me joy in my job? And I think there's a few things that I think are very helpful. I think number one, a gratitude journal. We're thinking about the things because I think we all in medicine we tend to just remember all the bad stuff that happened, but we tend to forget about the great stuff. And it can be as simple as maybe having a conversation with a sweet old man in the office that for like 2 minutes, but that just completely makes your day, right? And so I think, maybe thinking about what are the things that we're really grateful for, and um, the idea of what really brings me joy in my work, and even to that end, maybe before going into the office the next day or before going into the ER for another shift, having an intention, setting an intention for that day, or maybe having a mantra that is kind of your mantra that you say to yourself every day before you go to work. And I think, some of that can really help in terms of kind of getting us reconnected with why did I do this in the first place?
Yeah, yeah. I know that we can often use that against ourselves. The this is not what I went in here for.
Mm-hmm,
Why am I
mm-hmm,
still here? I don't see the point. Like
mm-hmm,
we can have this constant narration about our lives and perspective.
mm-hmm, mm-hmm,
Sometimes even the gratitude journal can feel a step, like even that can feel too hard. We look for evidence of how it's all wrong or all bad, but if we
mm-hmm,
just, like you said, find the sparkle, what
mm-hmm,
is, like, find the evidence, the other side of the story. It's one of the
mm-hmm,
things that the like, where did you have joy today? Where did you laugh today?
mm-hmm.
That guy in the waiting room who was just, he was polite to me. Oh, I had polite today, not just grumpy, irritable,
Right.
maddening, sad. I
Mm-hmm,
also
mm-hmm.
got a laugh, a
Right.
laugh.
Exactly. Exactly. Yeah. And yeah, I mean, undoubtedly, we all have those days where, it just seems like, oh my gosh, this is I just, don't want to be here and everything. But I think, being able to take a step back, especially when that feeling gets really overwhelming, being able to
Mm,
take a step back and think about, okay, what do I want this day to be like? You know what? I'm committing to I'm going to feel confident today. Like somebody maybe has lost their confidence or they're feeling a lot of imposter syndrome or something. And just sort of deciding, what? I'm going to feel confident when I walk in today. Or what? I had so many days when I would leave a shift and be kind of berating myself for, oh, I can't believe I missed that, or I didn't follow up. This patient's blood pressure was really high when she left, and I just didn't address that, and beating
mhm,
myself up for that. But then the next day, it's like, what? It's a new day.
mhm.
The slate is clean. I'm going in. I'm gonna I'm going to do the right thing. That was actually my mantra when I was a resident, was do the right thing, because I learned very quickly cutting corners was always going to be fraught with some bad thing that would happen.
It's funny how we have our things, isn't it?
Mm-hmm.
Yeah. Where does peer support come in now? How are you recommending that physicians look for support?
Well, I think so. There's a few, I think, different scenarios. I mean, I think the classic idea of peer support, I think, is after, an acute adverse event, when, you've just had a really bad case, like maybe somebody has died in front of you, or, you've done a procedure and you've caused a bad complication, something like that, that has just, it's been a finite thing. And I think it is important. And I think more and more institutions are really developing peer support programs. But, the whole idea of peer support is having, and I do think, of course, I'm biased, but I do think a physician coach is the ideal person to be supportive, because they're a peer, of the physician that's going through that, or, anybody in medicine, really. But it's so important to have someone that can listen, to let you vent, let you talk about, how am I feeling? And it's not even so much, it's not about what the case was, what happened. It's really about how this thing is making me feel. How am I dealing with it? And, having someone to talk through that with. And, I think there's also this whole concept of fact versus story. And so, a lot of people, they tell themselves a story that, oh, I screwed up, or I did this bad thing. When in reality, the facts are A, B, C, D, you couldn't have changed those things. And so I think one of the benefits of peer support is maybe having someone that can be more objective. And if there is a fact versus story kind of a disconnect for someone, maybe having someone that's more objective, that can maybe say, you know what, let's look at that. Really, your story is not really accurate. So that's the one, I think, place for peer support. And then the other idea of peer support is, I think, more of this kind of this idea of traditional ongoing coaching, where you're having somebody supporting you as you're maybe setting some goals for yourself, or maybe thinking about, this is what my job situation is right now. This is how I'm feeling, and this is where I want it to be. Now, how do I get from point A to point B? And having somebody support you through that journey.
Got it. Okay, beautiful. Where do people find you if they're looking to connect with you?
So I have a website. It is sjwprofessionalcoaching.com. And also people can connect with me directly via email. That is susanwilsonmd@gmail.com.
Perfect.
So either one is great.
Excellent. Anything we didn't talk about today that you wanted to talk about or leave our listeners with?
Well, you know what? I think we kind of hit everything. I do think, the idea of coaching as a wellness tool, I think, is really important. I think it is starting to get some traction, but there's still, I think, a little bit of resistance among larger healthcare systems to really provide that as a resource. And so I do think for people that find themselves struggling, certainly feeling cynical about their work, or feeling burnt out, feeling like they don't have balance, I think seeking coaching, is certainly, I think, a very effective wellness tool. And there's been so many studies out, even in the last couple of years, that have kind of corroborated that. So I think that's an important thing for people to remember. And of course, I'm very passionate about this concept of becoming mentally fit, because it's something that, basically supersedes, every part of our lives, not just professionally, but personally.
Nice. Thank you so much for your conversation with us today, Susan. I really appreciate your wisdom in this area.
Oh, thank you, Sarah. Well, it was great to be here and a great conversation.
Right. All right, everybody. See you next time. Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.